appreciate you bear with me. So we just went through all the different criteria for a substance use disorder, talked about how there's these 11 subsymptoms, and that these symptoms are common across all different forms of substances. So this is what you need to look for. Generally, we see a pattern here of somebody continuing to persistently use large quantities of a substance over an extended period of time in a manner that's somehow interfering with their life, either through social activities, giving up their own important activities, or even interfering with their health or safety. It also can include things like tolerance and withdrawals. And we mentioned the different severity categories as well, mild, moderate, and severe, and how we do still need to see distress or impairment going on in some form or another over the 12-month period of use of this level. So moving on from this, we'll go to the next slide here if I can. Let me see. I don't see that. Okay, so I just had a little bit of a hiccup there. Moving on, we want to talk about co-occurring disorders, right? It's a substance use disorder. And they say here, one or more non-nicotine substance use disorders and one or more mental health disorder at once is how they define a co-occurring disorder. Now, I personally take a little bit of issue with this particular description because who's to say that a nicotine substance use disorder couldn't also interfere with somebody in a mental health sense, right? Because when we think of co-occurring disorder, we're thinking about two things existing at once that are somehow affecting each other and your recovery, right? Mental health and substance use. Well, interestingly enough, one of the symptoms of withdrawal from nicotine is depressed feelings. And so I would argue that nicotine should be considered a possible co-occurring disorder as well, but that's just me. This is basically just information from the textbook, so just bear in mind that they say any one or more non-nicotine substance use disorder. But I'm not going to quiz you on that as if there's a right or wrong answer to it. In the past, we've said either a dual diagnosis or comorbid to describe these types of disorders. We tend to steer away from these terms now just because dual diagnosis can kind of pigeonhole us into saying there's just two things going on when there could always be something else happening too. And then comorbid makes it sound as if these two things are kind of one and the same when they are separate and unique and distinct disorders as well. So just some things to keep in mind. When we're thinking about treatment planning, moving on after we've done diagnosis, these quadrants of care can be very useful. They're also very useful in the diagnostic process. Basically, it's just 4 different directions based on the severity of 2 coexisting disorders, a mental health and a substance use. So SUD being substance use disorder, MHD being mental health disorder. As we see, quadrants are all arranged depending on which of these disorders is considered to be mild or moderate and which is considered to be severe. So, for instance, the first one is mild to moderate substance use and mental health. For number 2, it's a severe mental health disorder, so the abbreviation is a small s and large m to indicate the severe mental health disorder. So on and so forth for the other categorizations. Basically, this is just a way of conceptualizing the relative severity of either of these co-occurring disorders and in order to help you decide on placement and care, which we'll talk more about later on. There are 3 general treatment approaches for a co-occurring disorder. Sequential is when you're dealing with one or the more severe condition first, be it mental health or substance use. So you try and manage that the best you can before you move on to treating the mental health. For instance, somebody may be severely withdrawing from alcohol. They may also have severe depression, but we have to deal specifically with those withdrawal symptoms first before we start providing therapy for depression. Parallel is when you're doing both at the same time, but at different treatment facilities, right? So 2 different people, one person being a substance use specialist helping specifically with a substance use problem, while you go to a different facility that specializes in severe mental health disorders. So that may be useful if you're dealing with, like we go back up to this other slide here, if you're dealing with this large S, large M, right, severe in both areas, this person may need specialized treatment for both of these in separate locations. Integrated is when one person or one facility is doing all of the treatment for this person, be substance use and mental health. If this were a live lecture, I'd ask everyone what the disadvantages or advantages were for each, so I just asked you to kind of consider that as we move along. Some of it's pretty clear. You know that if you're trying to do sequential, if you're just ignoring one issue and just treating the other, you may not ever be able to fully treat somebody's, for instance, alcoholism if depression is a trigger to keep drinking, right? So if you don't help with the depression part, you may never be able to fix the alcohol part or get them sober until they have a few coping skills for depression. So there's a lot of different ways we could see these things as being helpful or useful in different avenues. A little bit of information. Alcohol use disorder, roughly 18 million U.S. citizens. I think this was a 2011 survey, met criteria. 5.6% of the adult population. Roughly twice as many men with alcohol use disorder than women. There may be genetic components to that, hard to say. There are other complications involved with alcohol, including the withdrawal symptoms. It can be very severe for some people, and they can include seizures, hallucinations, and delirium tremens, which is the severe shakiness that some people can experience during withdrawals. Of these, the most hazardous are the seizures. Those can be fatal, and so this is why some people need to very carefully consider the manner in which they are going to get sober and do that safely. There is an instrument, a tool, very important if you ever do want to work in a detox or residential facility, called the CEWA. This is a measurement based purely on observation. You observe symptoms in the individual who is detoxing. Scores can range from 0 to 6. A score of 15 or more indicates serious withdrawal. You will see this as an important part of your assessment if you are working in facilities where you can observe someone directly as they're going through withdrawals. This is also important for a nursing team to be able to use these regularly so they can determine the appropriate amount of services to provide for somebody. Drinking rates. This is very important. It is also separate from diagnosing someone, but an important part of understanding the history and pattern of somebody's use. First, it's good to also be aware of the standard drink. How much is considered a standard drink? Wine is 5 ounces, beer is 12 ounces, and liquor 1.5 ounces, which is about 1 shot, if that is 80 proof, which is 40% alcohol. That's how much an average drink is. Moderate drinking is defined differently for men and women purely because of different biological factors. Moderate drinking is 2 drinks a day for 14 or 14 per week. Women is 1 drink per day, 7 per week. That's considered moderate. Heavy drinking is defined as 5 or more binge episodes within 1 month. So of course we have to ask ourselves, what's a binge episode, right? What is binge drinking? Binge drinking, most scientifically, can be defined by reaching a blood alcohol content level of 0.08 or above. So that would be significant intoxication, enough to get you put in jail if you were to drive, right? That is what a binge drinking episode is defined as. Now, of course, it's the most accurate, but that's also very difficult to define unless you have, a BAC measuring device or something you can blow into at home, right? A more inaccurate way of trying to estimate this is for men, that would be 5 or more drinks within a 2-hour period. For women, it would be 4 or more drinks within a 2-hour period. And this was all just taken from the standards of National Institute of Health. Once again, this is not how we define a substance use disorder, right? Those were those 11 symptoms before. These are just ways for us to assess the extent to which somebody may be binge drinking. We also have to determine whether or not this binge drinking is interfering with their lives or that they're having difficulties stopping this type of behavior. So that's important to consider diagnostically. There are certain medications out there that are used to try to prevent relapse. Many different substances have these medications. Alcohol has a variety of different medications designed to try to help reduce the likelihood of relapse. One is called acamprosate or Campril. Campril is the most recently developed medication. Really, all Campril does is reduce the amount of time, or the severity, that is, of a craving for somebody. They will still report urges to drink or consume alcohol, but not to an extent where it's interfering with their lives or ruining their concentration or things like that. So I've heard good things about Campril, but once again, you have to take it 3 times per day, which is quite a lot for some people, especially in early recovery. Naltrexone comes in 2 forms, Rivia or Vivitrol. Rivia is a daily pill, so just once a day, a little better. And Vivitrol is a shot that you can get once a month. Naltrexone basically works by blocking opioid receptors. It just turns out that opioid receptors are the place that alcohol has the greatest addictive effect on the human brain. Strange enough, right? Turns out that when you block those receptors, one, you stop alcohol from having that same euphoric effect that it would have before, because that's what causes euphoria is when alcohol affects the opioid receptors. Two, it can also reduce the cravings, just the way Camprol can. This may be a little more complicated, but basically it can kind of help balance out the brain by blocking these opioid receptors. So this has been a very frequently used medication for those suffering from severe or alcohol use disorder, and they're repeatedly relapsing. So keep in mind when these these medications are most useful. Most of the time, it just has to do with how often and how severely they're relapsing. Disulfiram or Antabuse is actually the first medication ever designed and developed to try to help with relapse prevention. It was developed back in the late 50s. Basically, all it does is it suppresses a certain enzyme in your body necessary to break alcohol fully down into a non-toxic chemical. The enzyme is called acetaldehyde dehydrogenase. When you don't have the acetaldehyde dehydrogenase, then acetaldehyde builds up in your body. So basically, your body breaks alcohol down to acetaldehyde, then this dehydrogenase stuff breaks the acetaldehyde down into acetate, which is harmless. Acetaldehyde is not harmless. It makes you feel very sick if it builds up in your body. It makes you feel dizzy, facial flushing, it'll make you throw up. So naturally, once you take Antabuse and you block this enzyme, every time you drink, you're going to get a buildup of acetaldehyde in your body. That'll make you feel sick and throw up. So as you can see, that can help very directly with preventing relapse, because as soon as you start drinking alcohol, you're going to throw it back up. If you're a behaviorist, you also understand the paired association being developed here. Every time I drink, I feel nauseous, right? And so this can also help develop a paired association of nausea with alcohol, which can also help with long-term relapse. We don't use this medication as often in medicine because it seems very not harmful as much as distressing to use something like this. That's why a lot of doctors shy away from using this one. They'll usually try to use Vivitrol or Camprol first, but Antabuse is still prescribable, especially for people with major difficulties staying away from alcohol. Alright, so moving on to opioid use disorder. Something I really want you to keep in note here, that in 2011, although the rates had quadrupled from 1999 to 2014, we see that during that time, there was only an increase, 2014. That's really interesting. I just realized that I cited 2011 in the CDC, and yet this was from 1999 to 2014. I have to go back and look that up. But keep in mind that it is true that a quadrupling of opioid use disorders has occurred over about a 10-year period, 10 to 14 years. But even so, we see only 2 million cases of opioid use disorders right now. Let's go back and compare that to the 18 million U.S. citizens that still meet criteria for alcohol use disorder, 5.6% of our population, compared to 0.6%. So although the opioid use crisis going on right now is severe and debilitating for many people, it still doesn't even hold a candle up to the number of people affected by alcohol use disorder. Just keep that in mind, although the media points our attention in certain directions, many things can be taken for granted still, like the overall cost of alcohol use disorder on our society still compared to opioid use disorder. There are reasons why opioid use disorder is particularly troublesome and distressing for people. One is because this particular medication has been prescribed by doctors, leading to many, many people becoming addicted just for trusting their doctors to give them a safe drug that ended up being severely addictive. Another reason why opioids are so serious is because of they account for 90% of unintentional fatal drug overdoses in the U.S. So they are a highly fatal drug in terms of overdosing on them. Ironically, you don't really have a very large threat of death from the withdrawals of an opioid. Opioid withdrawal is very unpleasant. It comes with a great amount of nausea, diarrhea, heart palpitations, sweats, body pains. So there's a lot of really negative things that happen when you're withdrawing off an opioid, but the withdrawals from an opioid cannot kill you. The only way you could die from opioids is due to dehydration from the amount of throwing up you may have, and if you're not being able to take care of yourself. Otherwise, alcohol and benzodiazepines can cause a lot more serious withdrawals because of the seizures. Not the same thing with opioids, though. Still, very bad because of the overdose risk, especially these days with drugs like fentanyl out there. Medications for opioid use disorder include naltrexone, buprenorphine, methadone, and clonidine. Very briefly, buprenorphine, and methadone are both replacement substances that are longer lasting, but also less severe than things like heroin. They're designed to help people gradually taper off of these drugs without experiencing the cold turkey severe withdrawal that they may if they just try to quit altogether. Gradually tapering allows the body to adjust to lower doses of these medications so that they don't have to go through severe withdrawals like they would if they just stopped using a vast amount of heroin overnight. Clonidine is another medication that, and all it does is reduce the severity of the withdrawal symptoms. And like before, naltrexone or Narcan, that's the same thing as with alcohol up here. Naltrexone, as we see again right here. Same thing. It blocks those opioid receptors, which is even more effective when it comes to opioids proper, right? It helps with alcohol, but it's even more effective when it comes to preventing relapse on opioids. So a good thing to keep in mind there. Amphetamines and stimulants do cause withdrawals. They're just not as easy to notice. Most of the time it's things like depression, fatigue, dysphoric mood, insomnia or hypersomnia. But these can cause a lot of problems for people who are trying to get off amphetamines too. There are some medications out there currently that are supposed to help with relapse prevention. Bupropion is the only one really right now, and you have to use it off-label. It's called Wellbutrin or Zyban. It's an antidepressant. It's designed to help balance out dopamine receptors in the brain. It turns out that amphetamines react specifically to the dopamine pathways in the brain. Other medications and drugs do this in different ways, but amphetamines are the class of substances that directly stimulate your dopamine pathways. Bupropion can help balance out dopamine, so that's how it seems to have a good effect on preventing relapse on amphetamines. They also use bupropion to help with nicotine addiction and stopping people from relapsing on nicotine. So interesting again, as I had mentioned before, that depression tends to be a withdrawal symptom of getting off of nicotine. It makes sense that an antidepressant may help people stay off of nicotine. Other addictive substances include marijuana. You will be reading an article by Evans that talks about the genetic interactions between chronic marijuana use and psychosis. A lot of other important topics about marijuana will come later on. Good to know right now that an important thing to know is that marijuana doesn't currently have any sort of alternative medication to help with relapse prevention. Sedative hypnotics, that's in the F13 branch. So as you see, I put all these codes here, F12, F13, F16. Each one of these is how you diagnose or how you label these diagnoses using the DSM-5. So marijuana goes by F12. You saw before that alcohol is F10. This XX is just to fill in that there is supposed to be another number here. Typically, you can either put 10 or 20. So F12.10 would mean mild marijuana use disorder. F12.20 would be moderate or severe substance use disorder. There's a couple other codes that you can learn later on as well, but I don't cover those in too much depth right here. Anyway, as I was saying, sedative hypnotics, F13, either 10 or 20, include benzodiazepines, barbiturates, and other narcotics. You'll cover that in more depth in the book, so make sure to read through those parts of the book that cover these substances. Basically, keep in mind that narcotic really just means any substance that induces sleep. We misuse this word a lot, or at least government and law enforcement misuses the word narcotic quite a bit. They will oftentimes refer to as amphetamines as narcotics. In fact, you could go to a Narcotics Anonymous group that may mostly have people who were addicted to methamphetamine in it. that would be inaccurate to call that a narcotics anonymous group, technically. No one's going to actually mention this ever. This is just an important thing for you to keep in mind, that scientifically, narcotics do not refer to any medications unless they make you sleepy. Sedative hypnotics can make you sleepy, so can opioids, but amphetamines and caffeine, for instance, are not narcotics. Hallucinogens include MDMA, LSD, shrooms, I'm not going to try and pronounce that word, peyote, mescaline, ketamine. It also includes large amounts of nutmeg, can be a hallucinogen, and a few other things. There are no withdrawal symptoms in the DSM recorded for hallucinogens. And there is something different, though, called hallucinogen persisting perception disorder, HPPD, which is basically when people continue to experience disturbing hallucination-like sensations for long periods of time after they have ceased using hallucinogen drugs. This can be a very disorienting condition for people to experience. I've actually had a client or two report having these symptoms of recurring perceptual disorders after using hallucinogens. So very important to keep in mind and read more about that in the future if you get the chance, about how that happens and how you can maybe help people with it. Alright, I'm going to stop recording right now and maybe do one more. I just want to see how well this video is rendering without split screen. So I'm going to stop right now and then pick up with the last few slides very briefly after this.